Next, we're going to travel by the internet all the way to Australia and speak with Grahame Grieve, who for many years was Chief Technology Officer of Kestrel, a laboratory information systems company. Today, he's a consultant on interoperability. His company is called Health Intersections.
Well, Graham, I want to thank you very much for being with us today. I know it's either early or late in Australia. I'm not quite sure which. Um, but could we begin with your telling us a bit about your background and what led you into the world of standards?
Initially, I started working as a laboratory scientist. Um, After a stint doing that, I got engaged with a vendor that was selling us the laboratory information system and transferred to working for them. For a number of years, I worked as the development lead at that vendor, and much of the work that we did at the vendor, maybe 80 to 90% of the work for a while, was data integration of one kind or another. I increasingly got involved with the HL7 side of the integration with the clinical systems, and personally more and more interested in the standards community, the community space, and that led me to become more involved in HL7, and eventually I left the vendor and set myself up as a freelance consultant contractor doing interoperability of various kinds.
Well, that's interesting, and it makes sense because, as you and I both know, clinical labs were among the first entities in healthcare to adopt standards. So, segueing forward all the way to March 2011, in what I view as a famous blog post entitled The Rise and Fall of HL7, you said that we can create complex standards, but the market would ultimately reject them. Can you explain what you mean by that?
Well, we had spent at that stage 10 or 15 years creating very complex standards that set out to define the nature of reality, the nature, meaning of clinical information. And in our pursuit of getting full control over that complexity, we had developed ever more complicated specifications that people just couldn't make them work. And the market had rejected the more complicated variants of those. The implementation efforts had cost billions of dollars. National programs that squandered a great deal of money for other reasons than that alone, but definitely for that reason. Even the simpler ones now that are going to market are going to have a very big market backlash. That's quite evident right now. And by that I mean CDA. Um, that it's got a real impetus in the market, but the impetus will generate reaction. And it was clear that we could continue pushing complicated specifications, but ultimately the market would say, even if you impose this on us through a government regulation, we're not going to do it. And HL7 needed to find a fresh approach.
So, in that same blog post that you proposed or you stated the problem, you proposed a solution around JSON web services combined with a simpler data model derived from the RIM, and this has come to be called FHIR. Can you explain what FHIR is to the students?
So we started by looking and saying, people out there who are doing interoperability and getting kudos for doing it well, how do they do it? And um, the answer was invariably RESTful web services. It's a mixture of a set of technologies and a set of paradigms about how information is exchanged that make the solution simple, stable, easy to use in a whole variety of contexts, and technically very scalable. Also, there's a great deal of solid um, collaboration frameworks around security and authentication and so forth, which have all developed in support of the web. FHIR is just taking those base technologies and welding those with what we know about health information, about getting solid, reliable, safe exchange of health information, and just combining those two to produce an easier to use specification for exchanging healthcare information.
Well, to do that, FIRE attempts to define a subset of HL7 RIM that meets most day-to-day clinical needs, even for complex patients. And as I understand it, that's being defined as standards really should be through a collaborative process. Can you explain that process? How is FIRE actually being defined at the detail level?
Fundamentally, it's an iterative process. We have what are called domain committees. They're gatherings of domain experts from around the world in particular clinical or business process specialties within healthcare. We work with those domain committees to clarify the requirements that are common and shared, and then we draft the standard based on those requirements. Then we work with a bunch of implementation programs, national programs, vendors, and we hold connectathons where anyone can come and try these things out. We have a bunch of different tryout programs where we iterate those to where we think it's something that we can actually use in the specification. And then we, as HL7, ballots that, which process where all HL7 members can vote on the quality of the standard and ask for changes. Once that's balloted, then we publish that as a draft standard, and then the process starts again. Eventually, in a couple of years' time, we'll push it through to becoming a full-blown normative standard, but we're not in any hurry because we want to really run that iteration cycle as much as we can before we commit to normative standards are not changeable, and everyone's committed to them, and we want to get as much iteration done as we can before that we get to that point.
So I'm sure that feedback from actual adopters of FIRE is important to this process. How is FIRE adoption going? How widely is it being used today, and are you pleased with where we're at?
When we first laid out the project plan for FIRE, we expected that we would get a little bit of adoption interest at this phase. We've just published the first draft. It's effectively an early beta. We expected that we'd have a little bit of engagement with a few users, particularly in the space of personal health record access across the web. The web because the target technologies match, and that personal health access because it's basically new space and there's not a lot of established interfaces and communities and ecosystems. It's not working out like that. We're getting a whole lot of adoption in a whole lot of areas, more than we can deal with, and it's really tenfold more adoption than we expected. We didn't expect that because of the change part, that it's an early beta and that all of the implementers need to accept that the specification is still subject to change and therefore their implementations will have to deal with that. We didn't expect that to be the case, and it's just that the overall advantages of FIRE are so compelling that it's driving strong adoption now rather than having people wait to see how things develop.
Well, I think that you and the FIRE community are in the right place at the right time as adoption of digital records has grown exponentially, at least here in the United States where the government is promoting it heavily. People are beginning to recognize that without interoperability, the benefits of these systems, or many of the benefits, won't really be recognized, and so the attention is clearly turning to interoperability, and people are looking for a workable solution, and there you are with one. So congratulations. But one final question, as you look out a few years, where do you think we might be with respect to health data standards, FIRE, and interoperability in general?
I think, first of all, that data exchange is not something that solves any problems. And that's what we're working on. We're working to make data exchange cheaper so that it becomes just easier to actually exchange data. But there's no real outcomes merely for exchanging data. Beyond that, once we can exchange data, we need to have interoperable workflows, interoperable paths of care, Right now, those things can't exist because the data interoperability blocks those. So I expect that we'll have increasing focus on clinical interoperability rather than health information interoperability, and that will become more and more evident over the next few years. Looking past that, I would really like to see an environment where healthcare data availability is no longer the problem. Right now, it's a big problem for people within the healthcare process, the providers of the healthcare, and a big problem for consumers, although a lot of them aren't even able to recognize that. I'd like to take that away, so the question is no longer data availability, but what do you do with that? I think that we'll increasingly see the adoption of Health 2, which people often call patient-centered healthcare. That does depend on facile information. I think that we'll see aggregation towards a number of very few providers of very large healthcare record systems, and a huge differentiation in the provision of access and control and exchange of the information between the various records on the very large providers. And those very large providers will probably aggregate out of consortiums of large healthcare provider networks, which are forming now, and or national programs, and will probably cross jurisdictional boundaries. Those are the things that we're starting to see happen now, but they're still a long way away from being reality.
Well, I think you're absolutely right on. I particularly like your comments earlier on about the need to develop better and more standardized clinical processes and workflows. That is clearly going to be the next challenge after we have sufficiently standardized data. It's been great chatting with you. I'm sure the students have gained a lot from this discussion, and I can only thank you again for taking the time, either very early or very late in your day, to be with me today. Thank you very much.
Pleasure. Thank you.